All right, thanks. Okay, good afternoon, everybody, and welcome to our governing body meeting. Particular welcome to any members of the public that are listening or watching in on live stream, as I'm sure everyone appreciates the need to run these meetings virtually at the moment due to the restrictions placed on us by the COVID pandemic. There is an opportunity later on in the meeting for any questions from the public, so if anyone does wish to submit any, they can do those during the meeting. Any questions that are submitted, responses will be put on our website afterwards. We have already said that we have got a fairly lengthy agenda this afternoon, so anyone speaking, if they could just update on salient points, we'll assume that members have read the papers before attending. So in terms of apologies, there's apologies from Karen for later in the meeting. She has to leave at 4 o'clock, and Sam Crowe as well, who does receive an invite to the meeting, Sam being our Director of Public Health. Were there any other apologies, Steph?
No further apologies, Chair. All
right, thank you. So we are quorate. Just check if there's any new declarations of interest, gifts or hospitality.
Chair, please can I, on behalf of the Chief Officer and Directors or other executives present, declare an interest in agenda item 28, Remuneration Committee recommendations. All will be required to withdraw from the meeting for that item, and just to confirm the report has been redacted from their agenda packs.
Okay, thank you. So if we move then, we've got two sets of minutes to approve today. The first one was the meeting of the 13th of May. So if I just move through these, first of all, for accuracy, please. Page 1, 2, 3, 4, 5, 6, and 7. And then if we move to the minutes of the special meeting of the 17th of June, again for accuracy, page 1, page 2, page 3, 4, 5, 6, and 7. And if we now consider the matters arising of the meeting of the 13th of May, so as far as I see it, there are no outstanding matters. Was there anything else anyone wished to question or comment upon? Okay, thank you. So I'll go on then to matters arising from the special meeting of the 17th of June. Again, the outstanding actions have been completed. So again, I'll move on if there's no further questions or comments. Okay, thank you. So if I move now then to Chair's update, just one item really that's news from the past few days is the National GP Patient Survey. This comes out every year. We will likely receive a fuller report in due course, but it has hit the press today, and we have made a statement about it. So generally Dorset has performed extremely well against the national benchmarks. We absolutely recognise there is some variation and there are areas where we do need to improve, but generally speaking, a very positive outcome for Dorset. So it's very pleasing to be able to report that, and well done to everyone who's contributed to that. I'll move on to Chief Officer's update. Tim.
Thank you, Chair. The paper is largely as written, as you see in front of you. I'll just update slightly on the COVID update, in that we have now presented to the Joint Health Overview and Scrutiny Committee of both Dorset Council and Bournemouth Christchurch Pool, which came together, and they have been through a longer report which is publicly available, and obviously councillors then had the opportunity, as did the public, to ask questions on that. The spending referred to in 2.2, when we wrote that, we were running about £1 million a month for each of the trusts in Dorset. That has now increased, and we're probably closer to the 1.5 to 2 million. Apart from that, the report is as stated there, so happy to go straight to questions on it.
Okay. Okay, so I see no. Oh, there we are. One raised hand. Kay.
Tim, I noticed the framework put Dorset into the targeted support area of segment 2. Which areas did they identify for targeted support?
I think that's just an overall assessment of the CCG as opposed to a specific area which they wish to target that at. That was effectively, I would say, a global rating. I would say it probably comes back to the fact that we are struggling on a number of the key performance indicators that we were at the time of this, around some of the sort of 52-week weights. We were also struggling around some of the diagnostic weights as well, and some of the cancer targets. So that fed into the fact that they felt there was still targeted effort on that. But the overall classification itself is for the CCG as a whole, but I think they were the things that led to it.
Okay, thank you.
Okay, thank you. So if there's no further questions, I'll move on to strategy section. First item is the revised interim budget. Nikki.
Yeah, so again, the paper is largely as written. Just worth noting that the arrangements for August onwards have still not been concluded nationally. However, we are expecting something imminently. I will, however, talk to members in part 2 about the latest ongoing conversations, just to give you a greater update. Happy to take questions.
Thank you. Do we have any questions? Okay, thank you. So we'll go on then to the corporate objectives, paper 8.2. Again, these have you've already had an opportunity to comment on these. Aim to be in an understandable format this year for all audiences. And we've spent quite a bit of time within the organisation and also had an opportunity to share them with you as a governing body. Tim, was there anything you wanted to add to these?
I would just add we've done quite a lot of work with the sort of the staff over the year to try and get more sort of ownership and involvement of those. And what sits behind these then are effectively a further drill down by each individual directorate, and then people can then go further and drill down to staff level or team level if they so wish. So that this really sets the top tier of that framework, which allows for further more detailed specific targets by directorate, team or individual as the directors see fit. Apart from that, they are as stated there.
Okay, thank you. Do we have any questions on those? Okay, so we're being asked to approve these. Just can we confirm we're happy to approve? I'll just look at all the nodding heads. Okay, thank you. Good. All right, we'll move on. Thanks. So move on to the quality report. 9.1, Vanessa.
Thank you. So like others, I'll just assume people have read the report. The changes since the report have been written. The standard hospital mortality rate at Dorset County Hospital has gone down further and is now within the expected range. So for those of you that we've discussed this over a number of months, has now fallen into that expected range category. So that's very positive. You can see that there have been no events excuse me, at both Poole and Bournemouth Hospital. They're currently under review, and obviously the findings from those investigations will feed into the never event action plan that is being monitored through the quality surveillance group that I think I've mentioned to you previously. Moving on to the second page, in terms of other exceptions, the number of looked after children, we have seen an increase. What we have now have data from the last part of last year is that we have started to see an improvement in the completed initial health assessments within 20 days. So we'll continue to focus on that. It does obviously create a pressure with an increase in number of children looked after in terms of completing those assessments. But we do have the workforce back working completely on that now. The other thing just to point out is the SWOT call stack. You know that we've talked about this previously. The call stack risk has been reviewed and has reduced to 15. with the Ambulance Trust. And finally, I think the only thing to draw your attention to, if you've had a chance to have a look at the new quality overview link that's within the documents, it provides some more detailed information, similar to some of the information that previously was included on the scorecards, because we're moving over to that method rather than the paper scorecards now. So I'll stop there for any questions.
Okay, thank you. Okay, I've got a question from Mary and then David. Mary first.
When you say under looked after children, increased numbers of these children are going missing, do you mean literally going missing, or do you mean missing from the system and not up to date data?
Going missing and then being found. So not going missing from the system, but going missing from their temporary placement.
But then being found, that could be very, very worrying indeed.
Yeah. So in the annual report, we will pick up on those children that go missing and you know, how they're brought back into the system, how they're followed up.
Okay, David, has your hand gone down?
Great minds think alike. That was exactly my question.
Ah, right. Okay.
Okay, thank you.
Well, thank you. Kay.
Vanessa, could you send me a copy of the quality overview, because my link didn't work and I couldn't actually access it?
Yes, I will do.
Thank you.
So Vanessa, the standardised hospital mortality, that is good news for Dorset County, isn't it? We've spent some time in previous meetings and they did give us a trajectory, and it's really positive. And I know from speaking to medical director last week, he was very pleased to be able to report that. The other thing in the Dorset County box is about VTE. Again, that's something that we've raised repeatedly at these meetings. So is that therefore on track?
What we can do is provide some more details, because they're rolling out the pilot. So if the pilot is on track,
yeah,
the rollout will be telling if it's replicated across the trust.
Yeah.
So
okay.
we can make sure that we include some further information on VTE next time.
Yeah. Okay. Another thing with the never events, which you've highlighted, again, that's something that we've raised several times in the process for that. So just talk us through the steps for, you've said each is under review and immediate actions taken. So what's going to happen?
So what happens in terms of a process, there's a full root cause analysis investigation in each of them to understand what was either contributory factors or the true root cause. I know and the initial step is they have to complete a 72-hour report, so we have a good idea of any harm that may have been caused, and that we get early notification that a duty of candour has been exercised with the individual who has been affected. In terms of one of the never events, I know particularly there's been a notification that we've made to the MHRA, because of the labelling of the piece of the implantable device that was used was not distinguishable from a different device, so that visually they looked very similar. So that detailed analysis will pull out all of those learning points. We then share all of the learning from the never events through a panel that we've put together. That's a Dorset panel, so that with the intention that we start to make sure we don't replicate any of those events. Disappointingly, one of the never events in Bournemouth was a dermatology event that we have seen previously, and I think it was just in relation to the marking that wasn't undertaken. So that's the process. So we have that sort of feedback into the system. It would feed into, as I said, into the never event panel, to this patient safety group and to the quality surveillance group, so that we're completing the cycle of learning.
Okay, thank you. Mary, is your hand still up or is it up again? No, not down. Okay, that's fine. Thank you. Okay, if there are no other questions, then I'll go on then to the performance report, and that's with you, Phil. Thank you.
Thanks, Chair. It's the paper as read. Just a couple of quick updates. The Home First group is now starting to tackle the long lengths of stay that we've started to see increase. So this is a really good engagement between the acute sector, local authorities, and primary care. And there are a number of pathways identified where there are some quick wins that that can help, and we're at the very early stage of making that work. But that's a real step forward, and has come out the back of the experience with COVID. The second point is really about data, and we're seeing much better data flows now. The COVID dashboard, which allows us to see how many patients in what type of bed, oxygenated or ventilated or otherwise, on a day-by-day basis, is not information we've had access to before through the various organisations. So this is providing a really good basis for going forward. So our data quality to support decision making will really increase. But the rest of the data as in the report. So happy to open up for questions.
Okay, thank you. Mary.
Well, it was a comment, Phil, just to say I really like these new visual ways of presenting the data. So it was just to say, great, well done.
Great. Yeah, thank you, Mary. Thank you.
Okay, thanks. Vanessa? I think you're muted, Vanessa.
Apologies. Yes, no, I think that's really good, Phil, and I echo Mary's words there. I just wanted to ask you, and I know it's work in progress, but from the cancer referral trend from the 31st of May until the 14th of June seems to have gone down, and I know that's work in progress, but have you got any further update on that, Phil?
I don't have anything in addition to the reporting that I have there because of the reporting period. What I do know is that the team is making active efforts to outreach, and we've got a number of factors which are played in why the referral levels have dropped down. So there's the Cancer Alliance is making a proactive effort to try and pull people back in, because obviously we appreciate the risk that the longer they leave unreferred. But I can, as soon as we get the next batch, which will be before the governing body, I'll just share that.
Yeah.
So you can see what the moving position is.
Thank you.
David?
Yeah, thank you. Point 3.7 mentions endoscopy. I just really wanted to highlight concerns from a number of GP practices I'm linked with, who are getting letters back from endoscopy departments asking them to really revisit, look at referrals that they've already made, asking them to do tests, an H. pylori test, which actually isn't available in the hospital.
Okay.
And there's a real concern that we're going to be sort of double, our workload's going to be double because of having to go back over all our referrals, revisit them, and I accept that, you know, they are under pressure, but frankly, our referrals into secondary care over the last 3 months have dropped significantly, and I'm worried that the hospital's response is putting extra pressure on primary care.
Okay, thanks, David. It is recognised that that's happening. There are a number of factors that are being looked at. The endoscopy group, my view is that group is getting a much better grip on what the position is. We've had some overlays, which I'm sure you appreciate, with distancing and PPE type procedures, which has impacted the flow of patients through. So I think it's an attempt to try and understand what the quality of the list currently is of those people waiting, but recognise also that the H. pylori is a challenge too, because our diagnostics performance is lowered. So we're moving it from one list to another list almost, which doesn't really progress the patient, and that doesn't help. But I'll certainly feedback your comments, and I'll ask what we can particularly do about the pressure on primary care that's been created as a result of the overall approach.
Okay, thank you. Blair, then the feed, Blair. If you're speaking, we can't hear you, Blair. Maybe you're muted. Okay, I'll come back to you, Blair. Are you there now?
Yeah, I was just having a bit of a problem with my connection there.
All right.
Yeah, my question is similar to Dave's, which is about this time about the 1,000 people plus on the waiting list over a year. And I mean, we've discussed it before. We know what the reason is and the problems that we've faced, but have we actually got a CCG strategy to cope with this enormous number of, say, orthopaedic waiting list?
Okay, thanks, Blair. It's what we've set up is a health and care recovery group with the COOs working on the recovery strategy from COVID. So a proportion of the increased waiting list was obviously due to us having to pause all procedures, and the period of pause was quite significant. So quite a number of months, which has had an impact. Our strategy is we're focusing on individual therapeutic areas. We've got Alistair Hutchinson, the medical director at Dorset County, is leading on the clinical pathways, and we've got specific groups set up for each of those. I suppose I can give you assurance that our approach is good, but it's going to be a relatively long haul based on where we are today. So there isn't going to be a sort of a silver bullet or a quick fix for these things. What we have got, though, is we've got capacity in the independent providers. It's approximately 24% of capacity in independent providers, and we're working on the workforce for that. So we've managed to decant into that space, which has helped. But there's a number of factors. But the 52-week is at the top of my list of things that we're focusing on right now.
My concern is that if we are relying on private providers to get rid of our waiting list, and it's going to cost the CCG a lot more money, and we end up paying twice for a service.
Yeah, so if I just could clarify, we're not relying on the private providers, we're using the private provider capacity, but we're using it under the existing NHS commissioning arrangements. The providers have been contracted nationally by the NHS, so it's part of our national NHS command and control. Nikki might be able to give us a couple more points on detail if you want some more assurance on how that's working. I don't know if Nikki, if you're happy to do that.
Yeah, I'll just add to that. So all of the local independent sector providers are sitting under a national procurement process. That is likely to actually continue for the rest of the year. It's on a rolling contract basis, and we are not the commissioners for that. That is a national contract. So essentially for Dorset CCG and the Dorset system as a whole, that is actually a free good. And we just need to make sure that we're using and maximising that capacity as much as we can, which I think is essentially what Phil has alluded to. Hope that helps.
Thanks, Nikki.
Thanks. That's actually, I didn't realise that. That makes a difference.
It does, but it doesn't remove your concern that we all share about performance in terms of waiting times. That needs to be absolutely top of our agenda because we have too many people at this point in time waiting too long. Mafid. Sounds like you're muted, Mafid.
Yeah. I'm trying to unmute it, but obviously not control. Yeah. So I just want to reiterate on David's point about secondary care asking us to re-triage all the referrals, not just endoscopy. It's across all specialties. We've been seeing this, and also the Dorset community services, especially the dementia service as well, and that is putting quite a lot of pressure. And we need some dialogue, I think, with them, because I think it's a necessary step and shoveling the patient list around.
Okay, I'll come to Karen. You might want to comment on that because it's very live conversation on the regular CD calls with the acutes. Karen. I think we can hear you now.
Yeah, okay, you muted me. So yeah, it's a really live conversation, and I think what we're seeing is also pockets of specialties kind of going slightly out of kilter with the trend of the organisation, and we're seeing increasingly just pockets of consultants doing their own thing and going a bit AWOL, to be really honest. So we're having very live discussions with the medical directors. So I've got a number of contributions really to make. I think the first is that I think, I muted an idea a few weeks ago about having a primary secondary care interface group to try and address some of these issues, because the more we go on, the more I see that there is just this disparity between primary, secondary and community. And until really, quite frankly, the medics around the specialty get involved and get together and stop this, we're just going to see this continual bouncing of referrals, because it's actually easier to do that, to say, would you do X, Y, and Z, than actually just, they have to get a grip of the problem as well. It is a two-way conversation. But I still strongly recommend that we start where we can to promoting that conversation between primary and secondary care, where we'll actually solve some of those problems. And some of those conversations are starting already in certain specialty areas, which is really good. The second is, I guess I'd quite like to see, and I'm sorry if I've missed it, where we benchmark against our neighbours. So what's the size of our problem compared to the Southwest? And I'm just not sure I get that, unless I've missed it somewhere on the charts, about how well are we driving, what's the size of the problem, going back. And then the third reflects the conversation, the end result of the conversation we're having, the right conversations to be having is, how do we join up and create better pathways between the different sectors so that we get what we want? And actually that does mean that we probably will have to differentially invest in a different way. So instead of just saying we just refer to secondary care and we let them sort it out, I think increasingly with the drive towards, particularly through the endemic COVID situation, which is going to make it really difficult to go back to where we were, and who wants to anyway, but it will mean that we have to do more in general practice, and we can't do more in general practice without some investment coming in to support a different way of working. And I think that is a big strategic conversation that needs to be happening at ICS level. And it's one that's happening, kind of being replicated in all sorts of environments nationally as well. But I think with recognition that we can do more, we could and should do more in some situations, but you can't do more on the same resources. There does need to be a shift of either money or expertise or a new way of working, whatever that might mean. And I think the community diagnostic review will drive that, because I think it will put diagnostics firmly into the community, really where they should be, and where in many other countries they are, and will drive a different way of working, but we need to be able to resource that differently.
Okay, thank you. Martin, and then Tim. Martin.
Thanks, Forbes. Phil, it's the diagnostic performance that has an area of concern for me. But the other thing I want to mention, I did escalate the endoscopy thing through Colin Davidson a couple of weeks ago as a result of the networks I look after saying they were getting these referrals bounced. I think Colin has taken that forward and is trying to get a uniform one Dorset response to this, because as Karen's just said, there was some very isolated sort of silo responses coming from various units, which were confusing, I think. And I think they are actually on the endoscopy thing now and trying to start sorting that. The diagnostic bit, I've just come off a Southwest respiratory call. And to answer your question, Karen, as far as respiratory is concerned, the Southwest is all in the same place. It doesn't seem to be any variation. Spirometry is something that's going to have to be done in a very different way and not done in general practice. It's not showing on there as a risk. It seems to be, as our secondary care colleagues are saying, this is a huge risk. How is it going to be done? Where is it going to be done? And the outcome of this meeting was, what are the CCGs going to do about helping redesign this service in our primary care diagnostic hubs? But we've got to do it soon. So the diagnostic performance does worry me, because I think there's a lot more to it than mentioned on the chart there.
So if I could just comment on the spirometry again, that's something we've had, Karen and I were talking about last night with the medical director. So that's been taken as an action by the medical directors outside of the group. I have to say it'd be interesting to see what you heard on the call today, Martin, because what we were told in recent days was that in fact the decision now, or the guidance now, is that spirometry is not an aerosol generating procedure, but we don't have confirmation of that. So that might well therefore change the environment in which spirometry can be delivered. So again, that is something that has been reported to us, but as yet, I would say, unconfirmed. So that's what's been taken outside the meeting to try and sort out in the next few days.
That wasn't mentioned on the call today. They were all talking about airflow changes, negative pressure rooms, our appointments to allow for air changes. So no, most definitely none of the consultant respiratory physicians who were on that call were mentioning it as a negative aerosol generation procedure.
So this came through the Gold meeting, which Phil attends, and was presented to Clinical Cell last night. So this is vague, quite honestly. So that's why we're going to achieve clarity as soon as we can to answer that very question, because spirometry is very important and much delivered both in the acutes but equally in the community. So quite frankly, we need a pathway to address that. Tim.
Yeah, it was just very quickly to go back to Karen's point, just in terms of sort of comparative data. So we do have some, but not a lot. But in terms of the 52-week wait, we're definitely an outlier within the Southwest on that, and that's the same for endoscopy as well. We're an outlier on it. So I think that those two in particular, we weren't in a great shape going into the COVID position. And obviously there's been very limited procedures for 4 months now, so anyone who was effectively within 4 months of the 52-week waits will now have tipped over it, which is where the 1,000 is coming from. And endoscopies, as I said, we are just an outlier. Not all the areas in the Southwest are having the same difficulty around being able to continue that, or recruitment, or just the sheer numbers going through that. But those two in particular, as Phil said, we're really concerned about and want to focus on. But as Phil said, that there is not going to be a quick solution to this, especially with the current sort of PPE requirements, social distancing, etc. The beds being taken out, so capacity within the acute sector is not suddenly going to return to the pre-COVID position anytime quickly, and that's even with the independent sector's additional facilities.
Okay, thank you. So in short, there are performance areas that are of significant concern, and we need to keep a careful watch on these. We need a system response, not just an organisational response, to at least stand a chance of properly addressing some of these issues. And endoscopy, ophthalmology and some others are top of that list. All right, thanks for your questions. We'll go on to the finance report for noting with Nikki.
Thank you. So again, I will just assume that members have read the report. I just want to be clear for the public record that the 19.3 million reported deficit is a technical matter, as funding has been received for the year-to-date position as at month 2. We did also identify in the report 1.1 million shortfall in terms of that, but that has now been resolved with NHS England. So therefore, we are in a break-even position. I'd also like to note the information from local authorities, which we identified in the report as causing challenges for the COVID reporting. That has now resolved, and we have an improved reporting position as at month 3 for the hospital discharge programme.
Okay, thank you. Any questions? Okay, thank you, Nikki. We'll go on to Assurance Framework 9.4, Vanessa.
Thank you. So just 2 things. There are no gaps in controls or assurances to report from the assurance framework that you've got in front of you. The other thing to just update is we are making quite a lot of progress in updating the format of the assurance framework, with the intention that we will engage with the governing body members to bring a different version of the assurance framework to the September meeting. But there was nothing else that I really wanted to highlight. Thank you.
Okay, thank you. Okay, that's for noting. So we've no questions. So we'll go on to the Engagement and Communications Framework update, again for noting. That's with you, Charles. I think you're muted, Charles.
Forbes, the moderator is muting everyone, so it's really difficult to come on.
Right, it's just come unmuted. Sorry, Forbes. Nothing to add to the paper. 2 points really, just to emphasise really the greater emphasis on campaigns to support public awareness, particularly as we go into recovery, and secondly, just an important piece really for engagement to be an important part of that recovery planning, which we're taking forward the conversations on that. Happy to go to questions.
Okay.
Yeah, this isn't a question, just a comment. I've had a number of conversations with Ben and others about the communication strategy, and on the whole, I think it's worked very well through this period of crisis. And it's been particularly good that the CCG has, in a sense, been leading the whole system and brought people together. And Ben feels that overall relationships are much stronger across all of the areas and across the system, that this has been something which has bound them together much more, so it's been particularly successful.
Okay, thanks. Yeah, I think the comms team's worked well through this. I've been speaking regularly to Ben, as a number of others have, and I think we've worked hard to try and keep our messages current. I even noticed that we're now engaging in TikTok, Charles, under 2.5. I'm not sure what we did on TikTok. I'm not just asking that question to show that I know what it is. I just thought years ago we wouldn't have been on these platforms.
I think what's been probably a step change over the last year is our whole sort of digital media presence. TikTok, the latest, Instagram, is just a way of reaching a much wider audience. It's important still to have public conversations, but at this point we're having to use all the channels available to us, both for organic and paid for media coverage, but it's working well.
Yeah, and I know we're doing quite a lot through Snapchat in terms of social distancing, particularly as pubs and hospitality services open, just to remind people of the social distancing guidance. Okay, thank you. We'll go on then to the next paper, which is the organisational development framework, again for noting with you, Charles.
Okay, no further updates to the paper. I think Tim covered off the objectives particularly earlier on. I'll probably just pay particular attention to the change from April, which is to bring together the primary care training hub and the workforce system delivery team into one cohesive unit, working through a delivery plan which will be focused on both Dorset but also the national NHS People Plan, which we expect to see an update on next week.
Thank you. Okay, Sally.
Thank you. Yeah, just on that latter point from Charles, we're taking quite a comprehensive report to the next Primary Care Commissioning Committee in relation to the training hub developments and the support to primary care.
Thank you, Sally.
Okay, thank you. So go on to the annual report on the 2019 staff survey, again with you, Charles.
Okay, thank you. I think first this to say the report was delayed in coming back to the governing body, which would come earlier in the year, but due to COVID. That said, I think it's a good set of results, but obviously we need to continue that work. I think the People and Culture programme is particularly paying off well. We've continued the conversations with staff throughout recent months, particularly the Way We Work survey, the fact that we decanted our staff to home working. The only other thing I'd probably pick up now is, while people recognise this as an annual survey, as of today, the CCG has picked up on and is running with the new Nhs Pulse Survey. That is a survey that's been nationally commissioned, encouraging all organisations to take part. It's on a 2-weekly cycle with results due to be published within 24 hours. So I think it's going to give us a particular focus on how our staff feeling in the here and now, and we'll be able to respond to that in a much more timely way as well. So I'm really encouraging to see that. We're encouraging all our providers to do the same.
Okay. Thank you. If no questions then, thanks Charles. We'll go on then to the annual report on patient and public involvement. Again, still with you, Charles.
It's a fifth, isn't it? On this particular report, nothing to add. At this time of the year, we would normally publish this in line with the AGM. The AGM will be slightly delayed until, Steph will correct me, but I think it's September-ish when that's taking place. The one thing I probably would add to it is that we've been able to strengthen our service level agreement arrangements with our voluntary sector partners and other diversity groups in this year. So we're really working very closely with them in terms of public engagement as well. Nothing further to add. Okay, can I invite you if you want to pass comment on the report itself? I know you've been closely involved with Ben on that.
I think you're muted as well. Okay.
Yeah, sorry, I had so many documents open there that trying to get back to the actual thing to unmute myself was a bit complicated. Yes, I mean, I really like the format of the new report. I think it's much clearer and much more informative than last year. And I think Kim in particular has done a very good job on the way the report will be set out. I think the public engagement element of it is a real strength of the CCG in comparison to others by the sounds of things. And I think I was very pleased with what I saw.
Okay. Thank you. Okay, thanks, Charles. No questions. We'll go on then. So we'll go on now to the annual report for the infection prevention and control. Vanessa.
Thank you. So this is obviously the annual report for last year. It gives an overview of the areas of infection control that we monitor and have oversight across the system. I think worth noting is obviously the latter part of the year, the infection control teams across the system in the different trusts had worked together. I think during the response to the pandemic have worked even closer and set up quite a strong network. What is evident is the amount of infection control input that we needed to put into COVID, both in terms of the health sector and in social care, means that we will be reviewing if we have got sufficient resource going into next year. So the report is a standard report in terms of performance. So there was nothing else that I wanted to add to that, and I'm happy just to take any questions.
And can I ask about Clostridium difficile, which is just says it's an increase, but I think that's due to new reporting requirements, is that right?
It is. So the hospital reporting requirements reduced from a 3-day to a 2-day. So that obviously increased the people who would be attributed as acquired in care.
Yeah, okay. And then in the final page, page 6 under 7.4, the Infection Prevention and Control Conference, which was due to take place in June, it's been rescheduled. I just wondered if that was going to happen or happen in a virtual sense, because I know people really valued that event. They learned a lot about how we manage infection prevention and control.
We were hoping that by next March, which is when we were planning on having it, we would have a face-to-face. But obviously we'll have to keep that under review to see what we're able and what's realistic to be able to do. But I think what you're saying, Forbes, is you would rather there was something rather than just push it further down the road for a face-to-face.
Well, I think so. It's, you know, there's very active learning through this, and it needs to be current, doesn't it? So lots of other things have moved to a virtual sense, so I don't see any reason why something like that couldn't happen in a virtual way as well.
Yeah, okay. We could also look at doing some webinars or things.
Yeah, absolutely. There's loads of ways to deliver that message, and, you know, both in and very much out of hospital as well. Okay, thank you. So we'll go on to learning disabilities, mortality review, annual reports. Again, that's with you, Vanessa.
Thank you. So yes, this is just a summary of an overview of everything that went on in the LEADER programme. You remember this is a national programme that started in 2015. In terms of, there's a lot of data that's now included in terms of how we're performing. We are seeing an improvement in being able to complete reviews. So we've got a few more reviewers, but we did have some additional resource from Nhs England, so we're able to catch up on some of those reviews. And there is some sort of data in there to just explain some of the background of the outcomes of the reviews. I think what's quite interesting in 6.2, which was the whole point of some of the leader reviews, is trying to understand if there was any causation of death. So that section gives you quite a good overview where there was excellent practice or where there was care that fell short. And I'm pleased to say that there aren't any areas where there was a contribution to the cause of death. You'll see that there are some that this methodology wasn't applied because the reviews were conducted before the scoring system came in. But I think we have a good overview of the leader process. And as you can see in the report, we've got a good process as well for sharing the learning through the reviews. So nothing additional to report from the paper, so I'm happy to take any other questions.
Okay, thank you. Do we have any questions? It was quite a comprehensive report. I thought it was very helpful, actually.
So,
Karen.
I mean, I think this is a really good report, and I think this is one that I would say really should be shared with practices as well as acutes. So it's in the public forum anyway. I just wonder whether this is something that we could disseminate further than just us.
I'm happy to do that, Karen. What I'll do is I'll see how widely it's been shared already. So as well as the annual report, we do a quarterly update. So I'll look at what other means we've got to share that across primary care as well.
Thank you, Vanessa.
Thanks.
Okay, we'll go on to 9.11, Safeguarding Adults and Children Annual Report. Again, that's with you, Vanessa.
It is, thank you. So again, this is an overview of the safeguarding activity in 1920. I won't go into any of the specifics, but I think that it's fair to say that with the both new councils emerging and setting their own priorities, and obviously within our own team, within the CCG, we had a virtually 100% turnover of all our teams. So we are in the process of rebuilding that and strengthening those relationships with the local authorities as they start to embed. Having said that, we are fulfilling all of our duties under our safeguarding responsibilities, and we are creating good networks, particularly across our health safeguarding network, and obviously making more links within the multi-agencies. Our named GPs are working in quite a lot of different ways now, and I think they're involved with some of this PCN work as well. So we're trying to sort of branch it out a little bit further in terms of safeguarding. Because of the challenges in 1920, there were some objectives that we didn't meet, there are priorities that we're going to roll forward into the next year, and have quite a lot of plans for how to improve our safeguarding, not least having safeguarding dashboards and better means of having access to the information and performance in terms of safeguarding. So there is a lot in there, because obviously safeguarding covers a range of things. So I'm happy to go to questions.
Kay.
I noticed, Vanessa, that the numbers now for children have risen above both the England and the South West level in Dorset. In the past, the key issue has been there hasn't been the capacity to deal with the increasing numbers of children through the safeguarding route. Have any steps been taken to increase capacity effectively at the local authority to deal with this?
This is for looked after children.
Yeah.
Yeah. There's a lot of work that's going on in both authorities, and it's more sort of root and branch work rather than let's create some additional placement. So it's a more fundamental look at early intervention, early support. So there is that element of preventing a deterioration in a family situation that leads to a child being looked after. So that's more long-term sort of strategic look, but there are also plans that both councils have for creating additional placements. I know in Dorset particularly, they're having a real renewed focus on fostering and what that fostering support can look like. Fostering is always a challenge in terms of getting the number of people to be fosterers. And that's been a particular issue during COVID, where some of the people who would traditionally foster have had to shield and wouldn't take children and young people into their families. So it's a very live issue. It's certainly something that's constantly under discussion within both of the councils. But yes, they are looking at ways that they can increase their placements.
Because over both reports, over several reports, it's very clear that the demand is increasing significantly. And the early intervention is not necessarily working because the demand is still increasing. So we need to keep an eye on that, because that's obviously going to have health impacts down the line and everything else.
Yeah, and I agree with you.
Health capacity in Dorset.
Yeah, I agree with you, Kay. I think some of that early intervention is for next year, the subsequent years. There's something immediate as well that needs to happen that they are looking at as well.
Good. Thank you.
Thank you.
Okay, thank you. And I'd just like to say the visibility of the GP safeguarding leads has been very helpful through COVID. Sam and Izzy have been coming on to our weekly CD update calls and actually kept us really up to date with current activity and current advice. So I think that's been well done to them, quite honestly, for coming on a regular basis and keeping everyone informed.
I will say that I think that we will have to prepare ourselves for seeing an increase in safeguarding activity as we start to come out of COVID. We are preparing ourselves as much as we can for that, and making sure we've got the right resources to be able to respond.
Okay. Thank you. So we'll go on to Better Care Fund update with you, Sally.
Thank you. Yes, good afternoon, everybody. You've got the report, which is basically the closed down position for 1920, and then a current look in terms of 2021, particularly bearing in mind the impact that COVID has had. So for those that aren't very aware of the Better Care Fund, who are new to the governing body, this is a national requirement, and we have guidance each year about the content of the Better Care Fund. If I'm honest, the Better Care Fund for us in Dorset hasn't really been a vehicle to really push forward with our change programs, because we were doing that anyway. So the lot of the content and the narrative around the Better Care Fund very much features around our out of hospital model and the work that we've been doing about bringing teams together across primary, community, local authority, secondary care to support those most complex patients and people within our communities. So you'll see in the report we feature things like how we're working through primary care networks, what was our localities, and bringing those teams together, how we support carers, our work on ensuring that we've got good access to community equipment to enable and support people in their home environment. So that the Better Care Fund, as I say, hasn't really been, and I'm not sure that it has in other parts of the country either, a lever for change for us. It's actually been something that we've reflected some of the good work that we've been doing anyway. What is important, and that you'll all be mindful of, is some of the measurements within the Better Care Fund are things that are really in the forefront of our minds around non-elective activity, reducing people that are delayed in hospital unnecessarily. And so our strategy around developing the capacity and capability of our primary and community services, we believe will be the things that will have a sustainable impact on improving the outcomes in those particular measures. We did have our Better Care Fund signed off for 1920. We didn't get the national guidance until July 19. And there hasn't been any guidance for 2021 because of COVID. Nationally, they're reviewing the Better Care Fund, so we don't know what the future intention is in terms of whether that will be a continued vehicle where we show some of our budgets collectively across the local authorities and ourselves. We haven't got any truly pooled budgets other than the integrated equipment service within the Better Care Fund, where we do have risk sharing agreements, and that has been an area of financial pressure over the last couple of years. We are going to be helped somewhat with the COVID fund this year, so we aren't projecting a year-end overspending ISIS, but there is potentially an underlying recurrent concern for us around that budget. But as you can imagine, the more people we're supporting at home, the more pull there is on having community equipment. The other area is supporting those people with learning disabilities that were moved on from hospital some time ago, and we've got a pooled arrangement around that group of individuals, but that's very specific to those individuals. The other budgets that sit within that Better Care Fund are aligned budgets, and they're mostly within our contracts, for example, in our block contracts with Dorset Healthcare. So we've shared in here that we're likely to use the Better Care Fund as the Section 75 agreement as the vehicle to pass through and manage the resources that have come down nationally related to COVID, particularly around the support to care homes and discharge support. And we've highlighted that in the paper to you on within the content on page 4. So I'll close down there and open to questions.
Okay, thank you, Sally. Nikki.
It was just an observation in terms of 2.5.5 that I just want to ensure for the public record that we're clear that the CCG hasn't offered a 10% contribution support other than an expression of interest arrangement. It's just because the Better Care Fund obviously reflects both local authorities and CCGs. We're not clear yet whether or not that element will or will not be included in the Better Care Fund arrangement for the Section 75 to do with COVID. So I just wanted members to be aware.
Okay, thanks, Nikki. And I think we can say that in Dorset that money was passed on and gratefully received by the care homes. So I think it's been very helpful. Okay, thank you. So no reports, just note the following approved and draft minutes of primary care commissioning. So that moves us to urgent decisions, 3 urgent decisions again. That's with you, Nikki.
So in terms of the urgent decisions that were made, the first was in relation to the budget, recognising that we didn't have a governing body but clearly needed to ensure that the national arrangements went through formal governance processes. And the second related to the changes to the audit committee, which basically removed the GP member because we no longer had quality as part of the audit committee arrangements. I'm happy to take any questions.
Okay, thank you. So we'll move on now to questions from the public. Steph, I'll ask you to unmute and show your face, please. And I think we have had one question, which I believe is about telemedicine, but Steph, if you could read it, that would be helpful.
Thank you, Chair. Yes, we've received one question from the member of the public to the governing body. What is the current utilisation of telemedicine services within the CCG, and are we considering elevating the utilisation of these services during the present time and beyond? That's the end of the question.
Okay, thank you. So perhaps do you want to comment, Phil, and then we'll come to perhaps Blair and a couple of others if needed.
Thanks, Chair. So I'd just like to start by saying this was part of our strategy before we went into COVID. So we were already had started deploying a product called Attend Anywhere, which allowed consultants to have a consultation with somebody in their home through a secure system. The increase, we have seen an increase of uptake since the start of COVID, so that has accelerated. I'll bring Sally in if I may in a moment from primary care, because there's been an increase of not only the video type consultations, but something called eConsult, which is the ability for people to go onto the website and have an interactive form, which then routes through the appropriate service. So like maybe touch on that, and Blair maybe touch about My Health, because I think that's been made great progress. From an Attend just give you a sense of the change. At the beginning of March, we had about 50 consultations in a week that were being carried out. Mid-June data, which is what I've currently got, has increased up to nearer 700 a week. So there's been a significant step up in the number of consultations that are done that way. There's also Accurix, and there may be one of the GPs who's using it might want to comment on the use of that, which is another way of doing remote consultation. So I think we've seen a big step up. It was part of our strategy already. The intention is to continue this as part of our digital approach in a blended way, which allows people to use the various ways of communicating through interactive online forms. We've obviously still got the 111 service, direct telephone, as well as video consultation. But of course, where absolutely necessary, still face-to-face will play a role. But maybe Sally, do you maybe want to touch on the...
I'll come to Blair to do his digital bit, then I'll come to Karen. I know she'll have something to add, and then we'll let Sally mop up, shall we? Blair, because you're working on digital, aren't you? Okay.
Okay, thank you. Happy to comment. First of all, it's useful to differentiate between telemedicine, which has traditionally been thought of as patient-activated type of systems, and what Phil was talking about, which is managing acute care remotely. So, using video consulting, telephone consulting, and he mentioned e-consults. That's made a big difference. E-consults, just to put things into perspective, our practice alone sees probably about 500 video e-consults a week. That's just our practice, not the CCG. So it's being used extensively now. But MyAM Health, while using apps specifically to manage long-term conditions, is something which has been in the domain of the CCG for about 3 years or longer. And as a result of COVID, has had some extra funding to enable us to purchase many more licenses to use it. And we're rolling that out quite extensively now for respiratory medicine, COPD, and we hope to make that available for other long-term conditions, that's to say diabetes and cardiac, in the future. But yeah, 5,000 new licenses to be rolled out over the next 6 months, really. So a big investment.
Thank you, Blair. Karen?
We've just put in a bid to support hypertension management remotely as well, which would come to a value of £300,000 if we win the bid in association with the LEP. I think this is the future of long-term condition management, is to be doing much more. It is telemedicine, but it is also patient self-monitoring as well. So I think it's really important that we understand that it kind of covers both, but I think it will be an increasing strategy. When I look back, I think telemedicine, we've had a contract with Dorset Healthcare for as long as I've been a governing body member, actually. And it would be really good to re-look at the value of that contract and the benefit that we get from that, and how we move it into kind of the next part of our journey. The only tempering thought I have is about making sure that we don't increase health inequalities by digital exclusion by those people who can't afford to buy or can't access the digital means. And so I think we should be kind of really thinking very closely about tempering whatever we do with an equality impact assessment, which includes not widening health inequalities, and that applies to digital and telemedicine as well. But I mean, I do think it's the future, and I think that we're in a really good position in Dorset to be able to, really take the next steps, but also with the added value of a really population health management program, which enables us to identify those who are at greatest need, rather than just the people who think that it would be a good thing to do. So I think we need to also address where it benefits the population in the best way and in the greatest way, with the greatest impact, to try and improve outcomes. Thanks.
Thank you. Sally, anything to add?
Only one thing, because I think my colleagues have comprehensively responded to that question. I would just say that we're also taking the opportunity to get patient feedback on their experiences of technology used in primary care. So HealthWatch have been working with us as a system to gather that feedback. So that's another dimension that's really important, which builds on what Karen's saying as well, that when people are using digital, what type of experience do they have, and is it different for different parts of our population? So we'll be using that information and engaging with HealthWatch on that.
Sorry,
Yeah.
Fox, can I just add one more thing? Following on from the AHSN work that we did as well, we've kicked off a bit of work in a similar vein to what Sally describes around the patient and user experience of remote consultations as a system. And so I'm just going through an evaluation piece for the AHSN to firm up what that bit of work will do. And I think that will give us a really clear view on how people are viewing the different type of consulting that we're undertaking. Sorry to interrupt.
No, it's fine, thank you. So I think reflections from COVID are that this is probably one of the hottest topics that's been discussed in the learning through COVID. So the statements used are system first, digital first, not only to improve population outcomes, to make sure that through that we're reducing health inequalities as well. And we've heard that in all of the messages that we've had this afternoon. So Steph, can I assume that's the only question, and therefore that concludes the questions?
Yes, Chair, no further questions received.
All right, thank you. So under any other business, Steph, do you want to update on item 13?
Yes, please, Chair, thank you. Members will hopefully recall at the May governing body meeting, you approved the change of name for Westmore's Group Practice to Westmore's Village Practice from the 3rd of April. I've been recently advised that the change of name should now be Westmore's Village Surgery, not Practice. It was an incorrect name. It's a very minor change, but I just need to make sure governing body's aware because it has to be correct in our constitution and it went off as one of the amendments. So hopefully everybody will nod in approval. Thank you.
I'm going to assume there are no questions on that matter. Okay. Thank you. So that concludes the agenda for part one of our meeting. As the next meeting will be on Wednesday, the 16th of September. It says here venue to be confirmed, but I suspect we will all be in similar venues and not all in the same room at that point in time. So I would just like to say thank you to anyone who has dialed or tuned in to be with us this afternoon. But I do have to resolve that representatives of the press and other members of the public excluded from the remainder of the meeting.